All right, welcome to This Week in Health IT, where we discuss the news, information, and emerging thought with leaders from across the healthcare industry. My name is Bill Russell, recovering healthcare CIO and creator of This Week in Health IT, a set of podcasts and videos dedicated to training the next generation of health IT leaders. This podcast is brought to you by Health Lyrics, helping you build agile, efficient, and effective health IT. Let's talk. Visit healthlyrics.com to schedule your free consultation. If you missed it, we did 13 10-minute interviews from the show, from the HIMSS showroom floor. Women in Health IT with Sue Shade. Ann Weiler shared results from a Boston University study that showed better outcomes through digital engagement. Joe Petro, CTO of Nuance, showed us a clinic visit with no keyboard in the room, and that's welcomed. We talked policy with Anish Chopra, consumer experience with Andy Crowder from Scripps, identity and perimeter with Wes Wright from Imprivata, whole person care with John Glasser, and several others. I hope you enjoy these. Check those out on the website, thisweekinhealthit.com, or the YouTube channel as well. Our guest today is John Halamka, the geek doctor, as your book calls you, as I'm not calling you names here.
Right.
Welcome back to the show, John. It's great to have you.
Well, I'm happy to be here. And remember, geek is a term of affection.
Yes, to the technology class, it absolutely is. So you were really busy at HIMSS. In fact, we were both there for several days. I didn't see you once. It's 45,000 people. It's really spread out. What were some of the things that you were doing while you were down there?
Sure. Well, I had 35 meetings and 12 speaking engagements in 2.5 days, and I covered 75,000 steps.
Wow.
People actually said, I saw you everywhere. And I said, like, how is that? Well, because I was also in several videos that were playing in several places on the floor. And then I was in, screens and all the rest. So it was a wonderful experience to actually be in 3 or 4 places at once, which is what I've always wanted to do. So what did I see at HIMSS? So at HIMSS this year, the theme, of course, was patient-directed data exchange. Right, every HIMSS has a theme. In the past, it's been big data or cloud. And even last year was a little blockchain. Not so much this year. This year, it's with Seema Verma and Anish and Mike Levitt and Karen DeSalvo talking about some of the ways that the CMS and ONC rules are going to empower patients with claims data and clinical data, really kind of pushing us to a future where instead of provider-provider data exchange, it's provider-patient-provider data exchange, solving a variety of privacy dilemmas. Of course, we also saw quite a lot of APIs and FHIR, and then every other booth, machine learning, AI was big. So those are sort of your big 3 themes this year.
Big 3 themes. All right, so let's go back and forth on some of these. So let's start with, the federal government really has taken the center stage, literally. I mean, they took up a lot of space with their announcement, dropping it right before the show happened. There was a lot of talk on the floor about transparency, data blocking, information sharing, patient-centered patient access, as you say. And in that keynote, what we heard is they're really trying to restore market forces to an industry, that's almost consolidating to the point of opoly status. You definitely have it on the payer side. There's the payers have really consolidated. Now you're starting to see it on the provider side, of which I lived through it, and you're living through it where you're at. And some would argue on the EHR side as well. So, do these rules that have just dropped, do they help us? Really what they were trying to get to is patient-centric, as you described, patient-centric interoperability. Do these rules, obviously, I think we believe that they're taking us in the right direction, but, we've seen this before where the federal government tries to set a floor, but the industry doesn't react. Will the industry react to this?
Right, well, so let's look at the CMS rule, right? That's only 129 pages, much easier to describe. And what it was mostly about was giving us API access to payer databases, because although we've done a fair amount of API work, the Argonaut project on the provider side, the Da Vinci project on the payer side is novel. And so we saw with Blue Button 2.0, some Medicare data flowing, and now in that rule, they're saying, in fact, if you're Medicare, Medicaid, Medicare Advantage, CHIP, any of these government-funded or subsidized healthcare programs, you really need to offer this payer-based claims API. So will that happen? I think it will. The lift technologically is not that high. And of course, with every regulation, this is a notice of proposed rulemaking. You have to see in the final reg what the penalties and benefits are. One would guess, given the flavor of the current administration, it'll be more on the penalty than the benefit, right? I don't think there's new budgets for this.
Right.
So the only concern I have truly about the CMS rule is that state Medicaid organizations are traditionally extraordinarily under-resourced from an IT perspective. And we saw this, and remember back in the HIE, Obama days when you had a lot of state funding for HIEs, and the funding ended up going to the consulting firms. It didn't necessarily result in operational IT infrastructure at a state government level. So I think we just have to watch the state Medicaid side of that. So again, I think CMS fine. We'll see, hopefully, some notion of enforcement or embarrassment or something, unless you do it. Doesn't seem like too bad a deal. There's also the ADT provision, which you must exchange admit, discharge, transfer data as a patient goes through the system. And again, totally reasonable, technologically easy for providers to do that. HL7V2 ADT messages are ubiquitous and cheap. So I like CMS in general.
Yeah, so it was interesting to talk to some of the people in the innovation community and say, does this impact you? And almost to a person, it was like, not really. I mean, we sort of had to figure this out, 5 years ago, or we wouldn't be in business today. So it's helpful, but it's not going to dramatically change their existing business model. Do you think there's going to be new business models like you and I are going to get together in a garage that someday they'll take a picture of and say, Apple, this garage, and this is where John and Bill started their consumer-centric application that really transformed healthcare? Do you think that this will spur on the creative energy of the innovation community?
I do, and here's why. So all of this is just foundational data flow. This does not turn data into wisdom. So where you're going to see the innovation is when there are what I'll call data stewards that are aggregating this information and then turning it into action. And let's just give an example of how that might work. You probably saw 2 weeks ago, Aetna, CVS Caremark, and Apple announced an alliance.
Yeah.
And the idea with that is Aetna will give every member an Apple Watch, fine, so they'll get data. And CVS Caremark is both a service and a data provider. Apple will end up hosting de-identified, aggregated data and doing machine learning on it to figure out what motivates people to wellness. Because maybe, and I'm going to totally make this up, right? If you're a 30-year-old, you want a coupon. And if you're a 40-year-old, you don't want public embarrassment, right? Your friends finding out you're lazy. Who knows, right? And so imagine a set of services that are offered by companies started in garages that are now aggregating a lot of this new data that we're generating because patients make it flow, and then turn that into action. Better healthcare navigation. I think that lots of startups will start doing that. Yeah,
that's gonna be exciting. All right, so I'd like to talk a little bit about a different trend than some that you talked about, and one that we were talking about prior to coming on this show. We were sort of talking about consolidation and the changing of roles, and one of the things I've heard pretty clearly is that innovation, digital, and information are becoming really three roles within the organizations because the roles are so big. The chief information officer is really focused in on the EMR and the data side. The digital officers focused in on the consumer engagement and consumer experience side, and the innovation officers really focusing in on innovation, really trying to look ahead and to spur a community of people to innovate around the problems that specific health systems are challenged with and are addressing. So we talked a little bit about this. If you're willing to share some of your current direction, I think it speaks to that. But I'd like to hear your thoughts of where you see the different roles sort of evolving because I heard a lot of this from the floor. I've talked to a bunch of CIOs, and they're saying, my role is changing. In fact, your quote from last year, which was our number 2 quote for the year from the show, was the role of the CIO has changed totally. And I'd love for you to just talk a little bit about that.
Well, sure. So think about it. In a 1996-97 timeframe, when I became a CIO, it was about provisioning, compute, and storage, power and cooling. And then it emerged from there into, security and resilience and disaster recovery. Then it went into compliance. Well, now it's what cloud service for EHR, for email and productivity software, for financials do I procure, not provision. It's not CapEx, it's OpEx. Yep. So as you say, back then, 96, 97, I was the CIO, the CMIO, the CISO, the CTO, right? And so you went into the early 2000s where the CIO role started to split into multiple people in just that realm. But now, exactly right, we're looking at what is the digital experience for the consumer. That's a little bit tangential to keeping the trains running that the CIO might do. And then what is the next business model? Is it telemedicine, telecare? Is it home monitoring? What is it? And that's innovation. So as we merge Beth Israel-Lahey, and that merger takes effect on March 1st, I will end up being that innovation person, focused on questions like, does Alexa, Siri, Google Home make a difference in, say, the workflow of healthcare? If an elder can say, I need an appointment with my cardiologist in 2 weeks, can you make it in the morning? And it just does. Or instead of having people drive to a physical location, you're triaging based on a machine learning approach and figuring out what can be done virtually. And then doing, as Kaiser has, half of your visits in a virtual fashion. In fact, we move from building beds to building virtualists, clinicians that are sitting in an office like the one you're in now and doing teleconsultation. All of those are untested business models, and they really require a fast failure. Let's try it. Let's see what works. And a CIO probably isn't into fast failure.
Yeah. So so in that role, I would expect you're going to spend a lot more time with innovation partners. You're going to be talking to different voice providers out there, seeing what innovation they're doing. But you're also going to be listening pretty closely to the specific strategies that your new health system is going to be doing, and trying to marry those two things, because you're pretty pragmatic. You're not going to be talking about something that's 10 years out and waiting for it to come. You're really going to be looking at, I would assume, innovations sort of layered over years, I would imagine.
Well, so of course people say, what's happening 5 years from now? It's like, are you kidding me? Imagine predicting the internet in 1993, right? I mean, the World Wide Web, I should say. So what I look is 6 quarters ahead. As you say, it's very pragmatic. It's a technology that exists today, but just isn't evenly distributed, right? So that is, of course, we're seeing ambient listening being used in homes everywhere to connect your thermostats or your cameras, your doorbell. We're just not seeing so much of it in healthcare. So it's not unreasonable to believe that 6 quarters from now, we could have outpatient services running on Alexa, or inpatient workflow happening with Siri. And so let's explore those. So as you say, it's the Apples, it's the Googles, it's the Amazons, see what they're up to, how it could apply to healthcare. But as well, these lovely startups run by 27-year-olds in their garages that aren't as cynical as you and I. They don't actually know what's impossible, and therefore you gotta watch what they're doing. And I'm in Israel a fair amount too. There's a lot of fascinating Israeli companies around telemedicine, telecare, home care, Internet of Things, and such that we have to explore.
Yeah, so you probably went to a lot of meetings that were non-disclosure. I'm going to ask you for what's the one thing. I'll share the one thing that I saw that I thought is really exciting. I'd love for you to share one thing. The one thing I saw was the Nuance booth did a complete visit without the computer without the keyboard in the room, and you had essentially a device with microphones mounted on the wall in the room with a couple cameras so it could direct the microphones and pick up nonverbal cues. And it was essentially capturing the entire transcript on one screen, and on the other screen, it was actually using machine learning and AI to write the note and to essentially put that up there so that when the doctor was done, they could just approve the note and move on to their next visit. And that's just something we've been talking about for years, that this experience of looking at the back of the head of your doctor is not going to cut it moving forward. So voice gives us a lot of possibility, as you've discussed. Is there something that you saw that you were excited about?
So I will take your theme of using natural language processing, AI, machine learning to craft a less burdensome clinical experience to even tell you about a larger trend, which is machine learning not going to save us all, right? Got to be very careful about that. I wouldn't want to criticize any particular company's marketing strategy, but the likelihood that Dr. Watson is going to read 1,000 articles and treat you tomorrow with no human intervention isn't happening in the next 6 quarters.
Right.
What's happening in the next 6 quarters is I can say, oh, I have studied 1 million patients like Bill. And what I know is that I can improve Bill's lifestyle if I make these 2 or 3 interventions, if I offer these 2 or 3 incentives, and that kind of thing. The patients of the past informing the care of the patients in the future gets us closer and closer to a personalized medicine approach. We're already deploying 12 such projects at Beth Israel-Lahey. And it's simple things like, how do I schedule the OR? Who's going to show up to the appointment? How long are you going to be in an inpatient setting? And maybe we can schedule all the events in a Gantt chart and not randomness. Or how is it that I can figure out for the wellness care that is going to reduce total medical expense and improve quality, that I can put you through the right preventative rather than curative kinds of measures. All these sorts of things we're doing with existent 11 petabytes of patient-identified data hosted in Amazon Web Services, Google Cloud, and other places under BAAs to figure out the possible. And it works.
Yeah, it's interesting. I had a couple of CIOs. Well, actually, I heard of one major system health CIO say, I still don't trust the cloud. And I'm like, wow, I just can't believe that we're at this point. You almost have to trust the cloud for starters, and you have to figure out a way to secure that data and secure the transmission and protect that data. But there's just so many possibilities that are available to you. The other thing I heard was, people saying, I see, Google had a big presence, Amazon Web Services has a big presence, the Uber and Lyft, so you saw some of these companies start to come in and they had larger presence, and people were asking me, what's the practical application of, partnering with Google? I'm like, well, quite frankly, just go back and watch the show with John and I talking about it, and you shared how with that data you were able to look at things and then use FHIR to push different things back into the EHR to bring it back into the workflow. And I think that's the role of the CIO now, is to say, well, in partnership with the chief data officer and strategy, is to say, all right, we need to tap into machine learning and AI. Yes, it's not going to solve the world, but it's going to be incremental, significant advancements for every health system. So you have to figure out how to tap into it now, be playing with it now, get your wins, so that when it does, when that curve starts to really take off and you're able to do some pretty significant things, you're right there at the starting line, I would think.
Well, and absolutely. So imagine if the EHR, instead of being a dumb database, which is kind of what it is, it's transactional systems, gets the bills out, keeps you compliant, you were able to do semantic search and say, a month ago I saw somebody with a gallbladder problem. What happened to them? Now that would be a useful tool. So when you think about what Google does, sort of at their core competency is around structured search. So what if you married Google's technology with EHR technology, and suddenly it became a question and answer platform and not a data entry platform?
Yeah. Do you feel like you selected AWS? Does that sort of lock you in, or are you going to be able to tap into Google as well?
Of course, we selected everyone. So I have data on AWS. I have data on Google Cloud Platform. And with the merger with Lahey, presumably we'll end up with data on Azure. And also, all of my community hospitals, I have 5 community hospitals, all their data is cloud hosted. Meditech runs in the cloud, right? It happens to be NTT Data was their original partner. So the answer is that it's a right problem, right company. And I don't have any exclusive arrangements with anyone.
Yeah. All right. So another trend that I sort of picked up on was social determinants of health and health systems trying to sort of tackle that. And, we heard, roughly 80% of outcomes are non-medical, family history, personal decisions, financial education, housing, those kinds of things. We've actually talked about this before, but I want to take us in a little different direction. And let's assume that the financial models are aligned. I know that's a huge assumption, obvious, the business model, workflow changes that need to happen and adopting a new business model within the health system are important. But I wanted to take this in the technology standpoint. And so I wanted to isolate those variables so that we could talk about, how a pragmatic CIO would be looking at that. So I'm assuming we need new data sets, an ability to capture data from new sources. We need to be, picking up stuff from monitors, patient-reported outcomes, and we need to be able to figure out how to really go through that data, crunch that data, and deliver insights to the point of care. So since you're a pragmatic guy, how would you look at this as a CIO, given that the business model stuff has been taken care of? Are you looking at platform, I assume a platform, and where would you go?
Right. So you've asked a fascinating question. So we have all these new data streams, novel data sources, everything from your Fitbit to your sleep monitor in your mattress. Nokia makes one of those. But what do I do with it? Right? Do I put it in the EHR? Is it part of the medical legal record? No one really knows. What if I don't act on it? Do I get sued? No one really knows. So our approach for the moment, and I just say for the moment, is to store the raw telemetry from patient-generated healthcare data and devices in a separate database, and then run rules against that separate database. And when we generate an alert or a reminder, then that goes into the medical record. So putting 10,000 normal blood pressures in the medical record probably doesn't help anybody. But the fact that your blood pressure is significantly higher or lower now than it used to be, well, that's something we should act on, and a clinician could, in fact, avoid information overload or alert fatigue if they just said, I get on average 2 or 3 of these a day and they're all actionable.
Yeah.
So that's been our approach at the moment.
So you're interesting in that you've actually coded an EHR, and not something you're recommending people go out and do today. But one of the things we hear over and over again is, eventually the EHR provider will do this. In this kind of, let's just call it an era of faster movement within health and health IT and health business models, how are you thinking about innovation? Are you going to be innovating outside the EHR, or I would assume that you almost have to innovate outside the EHR, or you're going to be tied to their timeline of innovation?
And you're exactly right. So again, EHRs, transactional systems, compliance, bills will exist forever. But do I expect the next great innovation is going to be done by an Epic or a Cerner or a Meditech, eClinicalWorks, Athena? Probably no, right? They're going to build their good transactional systems, which we all need. They'll build the FHIR CDS hooks or the FHIR APIs for data gets and puts, for which then innovators connect and create value-added services that may run in the cloud or on your phone. And that's where the innovation is really going to happen. We'll call it the Apple builds the phone, but the App Store is where the innovation really happens. It's the App Store for health we'll see accelerate over the next 6 quarters.
Cool. All right, John, what other trends do you think we should touch on before we close out the show?
Sure. We can't close out a show without mentioning privacy and security. And the reason being that if we're sharing more data with more people for more purposes, and we're using cloud, and we're using mobile, and we're using Internet of Things, because IoT actually also means Internet of Targets. In effect, we've created our attack surface at, 10 or 100 times bigger than it is today. And so you need to put in place the intrusion detection and prevention, the monitoring, and in fact, probably machine learning driven systems that look for aberrant behavior, not just port 443 has got a lot of data, but the transactional orchestration doesn't seem to be quite right. Radiology images are being sent to the EKG machine. That wouldn't make a lot of sense.
Right.
And so I see, as I said, I'm in Israel a fair amount, an explosion of cybersecurity companies with novel technologies to help us build a foundation as our attack surface increases in size.
So that's going to be the place where we see, I think, I assume the majority of AI and machine learning being applied to healthcare in the, as you say, the 3, 6, 9, 12-month time frame. As opposed to clinical, we're going to take baby steps, but in security, it's probably going to be pretty significant, I would imagine.
Right. So let's take, for example, an imaging device, CT or MRI scanner. I'll give you a challenge. Go call up GE or Philips or Siemens or Fuji or whoever and ask them, so what protocols do you use on what ports and what orchestration can I expect? And you know the answer you're going to get? We don't know. Right? So there's no choice but to put in these machine learning services that say, I've looked at the last 1 million transactions out of the CTs and the MRIs. I kind of know what to expect. Here's one that's weird. That's the sort of thing you're going to see this year.
Yeah, and you also talked about the vectors. I mean, the vectors are all over the place. I mean, our data is now, I don't want to say scattered to the wind, but our data, as you mentioned, is everywhere. And do you have to sort of build your neural net, if you will, around all those directions that you're sending your data?
Yeah, and of course, there's no way we could figure out ultimately, as we go from business associate to business associate to business associate, how data ultimately gets used. But we can certainly control our borders, right? So that is, in my case, since with the merger, I'll have 13 hospitals and 450 sites of care. I'll have to control all the data flows in and out of all those borders, and then put in strong policies, business associate agreements, and auditing of third parties to help me understand what happens beyond the borders.
All right, last question around innovation. So a lot of different health systems set up innovation arms. Some are VC, they look like VC. Some look like just big sandboxes. You have tech stars like Darren's doing in Cedars, which is incubating small companies. What do you think your innovation arm is going to look like?
Sure. So my model is a bit different. And that is that I am not an accelerator or an incubator per se. What I do is I find third-party companies, whether that's a Google or an Amazon or a CVS or an innovator in Israel, and bring their technologies inside the organization where a team of 12 clinician engineers, these are folks, because it's Boston, right? We're Harvard, MIT trained people, then dissect those external technologies to look at the art of the possible. So we actually don't even call it innovation. We call it exploration. And that's hopefully going to tell us what will work in the next 6 quarters and not.
So you're not looking to monetize as much as you're looking to solve the problems that your health system has.
That's it. It's solve the operational business problems inside the organization using IP that may start outside of healthcare or start outside of us.
Fantastic. Well, John, as always, thanks for coming on the show. Thank you for coming off the farm and spending some time with us. I appreciate it. This show is a production of This Week in Health IT. For more great content, you check out the website at thisweekinhealthit.com or the YouTube channel. Easiest way to get there is thisweekinhealthit.com/video. And please come back every Friday for more news, information, and emerging thought with industry influencers. That's all for now.
Have a great one.